go looking for a pulse is high, that you see that change in heart rate or a sudden appearance of an organized rhythm, and that's your cue to go ahead and stop compressions and look. And I believe that we are stopping compressions at the wrong spot because we don't yet have the second piece of the puzzle, which is the evidence that we have a mechanical recovery as well. And that poor heart, which is trying to come back, is now suddenly exposed to another minute or two of ischemia because you stopped the compressions and that was all it had. So the idea of capnometry as being some sort of an indicator of perfusion is sort of a new concept for a lot of folks. You see that here. This is a printout from a Novometrics device where during CPR there's a very long period where end-tidal CO2 values are in the teens. You see it starts out close to 10, rises up close to 20. You can actually gauge the effectiveness of your chest compressions by looking at the end-tidal CO2 value. In this case, they actually stop compressions and delay about a minute before they shock, so clearly not on board with these short pauses, but were successful in any case. And you see the CO2 drop to near zero during the period of no CPR and then rise up to supernormal levels and then slowly settle in as the patient returns to normal circulation. So in addition to trying to predict whether somebody might have had return of circulation or not using the combination of heart rate and end-tidal CO2, the way that you can confirm that they have their pulse back is by holding compressions, and in addition to feeling for pulses, which is notoriously inaccurate, you can watch the end-tidal CO2 pattern. And if a patient is able to sustain end-tidal CO2 without compressions, they're alive, they're perfusing. If you see the end-tidal CO2 rapidly drop to zero, that's somebody who's still in an arrest state and you need to restart compressions quickly. Now with the end-tidal CO2, it's not quite as cut and dry. It's more of a situation where more is better or higher is better. You see that the value comes up, and if you needed a threshold, it's a value of 20. Interestingly, we see that value of 20 work both directions. Not only is a value above 20 indicate that you may have some chance that the patient's perfusing on their own, but in a patient who's getting sicker and looks like they're headed towards arrest, it appears that once you cross below 20, you've now got somebody who's got minutes left on the earth and is essentially headed right towards an arrest. So that's a nice anchor point, but again, higher values are better. So if you see the end-tidal CO2 actually overshoot, that's a very good sign. It likely means that your body is willing to shunt blood to muscle groups that haven't been perfused for several minutes or longer, but that circulation is now suddenly so good that you can sort of wash through all that CO2 that built up during the arrest.
Now lastly, we're urging you also to code your patient where they are rather than try to transport. I also have an EMS background. I used to work as an EMT, and I know from experience it's very difficult to do chest compressions while you're loading up a patient on the gurney, while you're wheeling the patient to the ambulance, while an ambulance is moving around in traffic. It's really difficult. Your patient has their best chance of getting return of spontaneous circulation with the best quality resuscitation you can give them, which usually is wherever they are. And we understand sometimes the scene is unsafe for various reasons, and it requires the patient to be moved. But whenever possible, you should keep the patient where they are until return of spontaneous circulation has been achieved or until the patient's going to be pronounced deceased. Lastly, with adults, I want to talk about the concept of rescue breathing. Now, rescue breathing implies that the patient has had return of spontaneous circulation. What does that mean? That means the patient has a pulse and has a blood pressure. Now, the recommendation is to ventilate the patient once every 6 to 8 seconds. That means we're looking for a rate in the range of 7 to 10 breaths per minute. It's very easy when the adrenaline's flowing to breathe much faster for the patient. But remember, every time you ventilate the patient, even if they have a pulse back, you are blowing away their venous return back to the heart and you are dropping their blood pressure. So watch very carefully at the rate that you're ventilating the patient. Now with pediatric BLS, the same principles apply. We want to drop down, we want to get continuous compressions, we want to minimize ventilations as well. We're looking at a rate with one rescuer, pediatric BLS, of 30 to 2. Again, this is all done for simplicity, just to help it be fresh in your mind as to what to do. With two rescuer, though, it's 15 to 2. And we want to get those two breaths actually not on either end of the compressions, but we actually want to ventilate every 7 or 8 compressions as we go. We want to squeeze the breath in between the compressions so the compressions are not halted for any reason. So let's talk about a case that's very specific to pediatric BLS. A 2-year-old female presents to EMS after a febrile seizure. She's apneic and cyanotic, but does have a pulse. Bag valve mask ventilation with 100% oxygen is started. The monitor shows a sinus bradycardia at a rate of 40 per minute. What should we do next? So in the case of young children, if the heart rate is less than 60, what you're going to do is you're going to support ventilation first. Now, with pediatric cardiac arrest and these symptomatic bradycardias and such, most of them have an airway cause. So the patient became hypoxic for whatever reason, and that's the reason that their heart began to slow down. So what you're going to do is you're going to take 1 minute of trying to ventilate the patient with oxygen. If after that 1 minute the heart rate has come back up, then you provide assisted ventilations and you prepare the patient for transport. If after 1 minute the heart rate is still less than 60, then you treat the patient as a cardiac arrest with chest compressions and ventilations.